Great. Welcome. My name is Carrie Neiman. I'm one of the core faculty members at the Johns Hopkins Cochlear Center for Hearing and Public Health. And so welcome to the keynote address of the Cochlear Center Research Day, and also welcome to the current EpiCurrent topic seminar. So welcome to both parties. I will just go over a couple logistics here before I introduce our keynote speaker. So for those of us joining in person, please hold questions until the end. We may have a little bit of time. If you don't have time, please feel to join us for some of our later events today. Closed captioning is provided, and you can access that link for those of us who are joining online, as well as up here, the cart reporter. If you're joining via Zoom, you can use the Q&A function to ask questions, and please reach out if there's any technical difficulties. So with that, I'll go ahead and introduce our speaker. We are very honored to have Dr. Leroi join us today. Multidisciplinary work is very much a defining part of what we do at the Cochlear Center for Hearing and Public Health. And I would also argue that it is what underlies rigorous and impactful work as well. And that is very much what Dr. Leroy's work is all about within dementia care. Dr. Leroi is a professor in geriatric psychiatry at the Trinity College Dublin and is faculty within the Global Brain Health Institute, as well as a consultant geriatric psychiatrist at St. James Hospital in Dublin. She trained in Canada as well as in the United States, which includes time here at Johns Hopkins in the neuropsychiatry program, and was a professor of psychiatry at the University of Manchester, where she founded and led the Greater Manchester Dementia Clinical Trials Program. She was global lead for a 5-year program grant, SENSE-Cog, which will be sharing some of that today, which involved 5 European countries. She now leads the HRB CTN Dementia Trials Ireland network, and also the 4-year HRB APRO program, Emerald Louis, which aims to improve diagnosis and care for people with less common dementias in Ireland. I will also add on a personal note that she is a constant advocate for patient and public involvement to guide and inform research in an area that has been underrepresented in terms of patient and family voices, especially within dementia care. So thank you for joining us and for advancing work in this much needed space. So thank you. See if I can get that text bigger. That's not what I'm going to say, by the way. Right, thank you.
Thank you so much for that lovely introduction, Carrie, and thank you to Professor Lynn for inviting me here. It's absolutely a tremendous honor, and also personally very important because I'm at that stage in my life where I'm starting to close my circles. And as you heard, I was here at Hopkins for 4 years, and in fact, my son was born across the street there in Osler, and I left just after he was born, and he's now 22. So this is my very first trip back to Hopkins, so it's delightful to be here. Trinity College Dublin is one of the ancient universities and partnered with Oxford and Cambridge, started in 1592. And we have one of the most beautiful libraries in Europe. So if you do come to Dublin, please look me up. And if you look closely, you can see my desk just behind that shelf of books there. No, actually, these are precious collections, but it's a beautiful library. So please do make the effort if you come to Dublin. You heard also that I work within the Global Brain Health Institute, which is partnered between Trinity and University of California, San Francisco. And the goal of the GBHI, it's a leadership training program for global brain health leaders around the world. And it started in 2015 with the legacy of Chuck Feeney. And it's absolutely deeply embedded with interdisciplinarity. So you can see some of our current fellows. We have Paul here, who is a dancer from South Africa. We have Fifi there from Indonesia. She's a geriatrician. We have Kanyo, who's a geriatric psychiatrist from South Africa. We have Dominic, who is a playwright from Leeds. And this really embodies this idea of, requires all these people together to address this wicked problem of challenges to brain health globally. We've had one person in hearing health, David Luffrey, my lovely colleague, who did a beautiful systematic review of the literature, and he was one of our fellows as well. So forgive me, but I've taken the opportunity to put some recruitment pamphlets down there in the front. So in fact, what is the challenge? Well, you'll all be very familiar about the rising prevalence and incidence of dementia worldwide, looking at over 130 million by 2050. But what is absolutely critical about this is that where the overall worldwide burden of dementia is not here in the United States or in the UK. It's actually in lower and middle income countries, what is now known as the majority world. So 66% of the overall burden of dementia is in the majority world, and it is rising rapidly. And this is one of the key things that we need to address. Now, it's an exciting time for Alzheimer's disease, as you'll all be aware. We're into the era of disease-modifying therapies with the new licensing of, not in Europe, aducanumab, lecanemab, and donanemab. And whereas this is an extremely exciting time, actually, these treatments and advances will be relevant to only a tiny proportion of the world's population with dementia. You need to be early enough in the course of the disease. You need to be biomarker positive. You need to have a means to detect your biomarkers. You need to be able to afford the medication, and you need a health infrastructure that allows you to deliver the medication and monitor side effects. So again, thinking about the global context, you can understand what a tiny proportion of people these medications actually apply to. So we're now in this post-Donepezil era. And when I first prepared this slide, it was actually very much with a kind of a pharmacological perspective. But actually now, looking at the evidence, this post-Donepezil era is absolutely critical for non-drug interventions. And that's where what we've been talking today absolutely comes to the fore. Now, I'm not going to embarrass people by asking what this is, because when I asked my own residents who train in psychiatry what it is, somebody said it was a fetus. Now, that's not a fetus, that's the hippocampus. And there's a hint, there is a hippocamp, a Greek seahorse right there. So that's a hippocampus for the post-Donepezil era. So what am I going to talk about today? So here's my outline. I'm going to look at the context of hearing loss and dementia, but also vision loss, because again, hearing loss, vision loss, so sensory loss overall comes together. I'll look at it in the context of the clinic. By the clinic, I mean the memory clinic, because I'm not a hearing and vision scientist nor clinician. I'm a frontline dementiaologist, and I work in a memory clinic, looking at the diagnosis and support of people with memory and cognitive difficulties, as you've heard. So for each of these, I've picked out a kind of a key theme, but starting in the memory clinic, then I'll shift to looking at the context of a person living with hearing impairment and dementia at home with their care partner, then moving into the care home, the long-term residential setting in Ireland, and finally at the very end, talking about settings in the majority world. And I hope we'll have time for all of these. And as you can see, I've picked out a theme in each of those areas. So let's start with a little bit of context. So I just put this up because this is a poster that I came across when I went to a photography exhibition in North Vancouver. I went to the University of British Columbia for my undergraduate. It just says a lot. I'm not crazy, I lost my glasses. In other words, this relationship between sensory loss, sensory impairment, and your mental state and your mental well-being that we've heard a lot about this morning. And I framed this poster and I've taken it around with me around the world, and it's sitting in my office, reflecting on this kind of this interrelationship between cognitive and mental health and sensory change. Funny enough, many years after I got this, just in the last couple of years, I thought I would look up this photographer, Lonnie Shavelson. I don't know whether any of you have heard of him, but turns out he's a palliative care doctor in San Francisco, and does a lot of work around equity, working with particularly people who are homeless and thinking about the end-of-life care pathways. So, impact of hearing loss and dementia. Now, this will all be very well known to you, but to set our context, risk of isolation in older people. Now, again, we've touched on that this morning, and I'll come back to this theme as well. And some of these data, of course, are from here as well. Greater healthcare utilization, but there's a little bit of a caveat there, which I'll come to. More rapid cognitive and functional decline, increased neuropsychiatric symptoms, which of course in my work as a geriatric psychiatrist is critical because we have this huge challenge about the overuse and misuse of antipsychotic medications. So if we can address these symptoms in different ways that are non-drug related, we are going a long way in terms of being effective as clinicians. Depression, we've already heard about today, communication barriers, and so on. And all of these are well known to all of you, ultimately leading to an impact on quality of life, not only for the person with dementia, but also their care partner. And that's a theme I'll keep coming back to. Again, the role of the care partner. So I'll draw your attention to this beautiful white paper. It's called an APPG, or All-Party Parliamentary Group. This is from the UK, and it's an example of one of the initiatives that are put forward to bring to the attention certain key issues. And it's about this idea of dementia and comorbidities. Dementia never travels alone. So again, it's intimately linked in with what we're talking about hearing, sensory loss, vision loss, even olfactory loss in people living with dementia, and how important it is to recognize the holistic aspects of sensory cognitive health. The other point about this, my previous slide, I mentioned about the increased healthcare use in people who have comorbidity in terms of sensory cognitive health. But actually, the evidence also suggests that prior to the point of crisis, people with sensory impairment and dementia actually are less likely to access non-urgent services. And that is a critical point. So we talk about isolation, we talk about loneliness, but we also talk about lack of access to care and closing in terms of what people have access to and the impact that has on health outcomes. So the SENSE-Cog program, which you've heard about from Kerry, this was a 5, actually 6 because of COVID year program, which I led, funded by the European Union, the Horizon 2020 program. And it came under the theme of improving mental well-being in older adults. So there are a number of projects funded under that theme. But again, it really stresses this idea that we're looking at sensory cognitive health with this broad picture of well-being and quality of life. So some of the findings that I'll talk about today will relate to the work that we've done in this program, and you can see our website online. We had multiple work packages, including some epidemiology, some adaptation of cognitive tools, a large-scale clinical trial, which I'll mention, as well as some work in quality of life, and importantly, patient and public involvement for this community of people living with dementia and sensory impairment. So let's go to the memory clinic. So I've presented the slide a number of times. If you look closely, you can see 2003, it's very old. So this is from my colleague, Harry Allen, when I first moved to Manchester, having left Hopkins in 2002. And we worked in the same memory clinic, and he did a fairly straightforward audit of the people referred to the memory clinic from primary care with cognitive difficulties. And he came up with this very stark finding, that 80% of referrals to the memory clinic, in fact, had clinically significant hearing impairment that had never been diagnosed or detected. And the reason I keep this slide in is because actually, more than 20 years later, this hasn't changed. And the audit of most memory clinics will come up with the same stark figures. So here is something that is potentially easily addressed, and yet it still isn't. What about vision? These are data from the PROVIDE study, a very elegant cross-sectional prevalence study, a very pragmatic prevalence study that was led by the College of Optometrists by my lovely colleague, Michael Bowen. And again, the same kind of idea that is a significant proportion of people living with dementia who are not accessing the care, because 22% of people have vision impairment that is clinically significant. And of that proportion, 2/3 are correctable with glasses and cataract surgery. These are simple, cost-effective interventions for people living with dementia, and yet they're not happening. So setting the theme here for what we did in the memory clinic, I'll focus on one particular thing. And this is the impact of hearing impairment on cognitive performance. Now, our bread and butter in the memory clinic, of course, is cognitive performance, and our cognitive tests are hearing and vision dependent almost entirely. So when you have a person who has hearing loss or vision loss, it's extremely difficult to try to ascertain what their cognitive function is. And so therein lies a challenge. So this is a very classic study which essentially looks at the relationship between your performance on the MMSE in relation to your hearing impairment. And the bottom line is that you will perform worse for a number of different reasons. The very basic one is that you cannot see and hear properly in order to be able to do the tests. So this set the scene really for one of our very first studies within the SENSE-Cog program, was to do a scoping review of the various tools for identification of dementia in adults that had been adapted for hearing and vision impairment. Now, this is already a few years old, it was published in 2017, so the field has moved on. But I think the findings are still important because essentially it showed this, that the most common test adapted for sensory change was the MMSE and the MoCA, the Montreal Cognitive Assessment Test. I'm not sure whether I'm allowed to say this in this setting, but the MMSE is really not very much used anymore outside of certain settings, this being the birthplace of the MMSE. But because of those certain challenges to do with copyright, the majority of people around the world are using the MoCA or the Montreal Cognitive Assessment Test. And the difficulty, however, that in spite of having the availability of the MMSE and the MoCA, which have been adapted, both for vision loss and hearing loss, actually they are not really fit for purpose for two reasons. First of all, because the items that are dependent upon either hearing or vision were simply deleted. Secondly, they haven't been validated in these populations. So you're dealing with flawed tools that don't correspond with their original versions. So our first step was to take these tools and do the job properly in essence. And the way to do that is by item substitution rather than deletion. So let me just briefly share that with you. But this is the protocol for how we did that. The first point is why we did choose the MoCA, and main reason is because it's so widely available, and also because you're allowed to pull out a bit of an executive dysfunction element, which you cannot from the MMSE, but also because it's available in the 27 languages of the EU, which is very important for our purposes. So how did we do the substitution? Let me give you an example. So here, for example, is the vigilance test. So on the standard MoCA, the examiner will read the list of letters and the person would tap when they hear A. However, if you cannot hear, that becomes a challenge. So the substitution test is instead making this a visual task. So when the person sees this circled number, they can indicate. So the obvious question is, what if they can't see? When we started this work, we had a rather grandiose mission of thinking we could adapt the MoCA for both hearing and vision impairment. But actually, that proved to be far too challenging. So we have separate new versions of the MoCA H and the MoCA V. And in fact, we've now validated them and they perform extremely well and are appropriate vis-a-vis the original tests. And as you can see here how it performs. So for those of you who are interested, you can now get them on the MoCA website. And here is the outcome paper for the MoCA H, and the MoCA V will be coming out very soon. So that was some of the work we did in the memory clinic setting. Let's now move to living at home, the person with dementia and their care partner. I'm going to focus on two things here: efficacy on dementia outcomes and hearing aid adherence in this population. So when we started this program, we didn't have data from the ACHIEVE study, that's for sure, but we did have some retrospective data from ELSA, the English Longitudinal Study of Aging. And my lovely colleague Asri Maharani did this beautiful sort of a spline model here, in which she took data from ELSA across multiple waves and put a knot in the data at the point where people received a hearing aid. And basically what you can see is that prior to the hearing aid being administered, you can see the change in the trajectory of cognitive decline. So this was some quite strong data to suggest that actually there's a signal there and we should be doing something in terms of intervention and cognition for older people. Now, the big criticism, of course, is that the data does not tell you whether people continue to use the hearing aid. They just got it, it was prescribed. But in fact, we redid the same study, a similar study, using the HRS data, and actually we found that with cataract intervention rather than hearing aids, we saw very much the same effect. So the cataracts, of course, more robust because you can't reverse them. And again, you can see that change in the trajectory of cognitive decline before and after the intervention of the sensory change. So the setting was clear that we should move forward on looking for an intervention to try to improve dementia outcomes through sensory intervention. We went to the literature, and again, this is, really going back to 2018, which isn't that long ago, but the world has changed. And actually, we found very little. 12 studies of hearing intervention, 5 studies of vision, no study that combined the interventions, and most were low to moderate quality, with very little of the kind of holistic type of intervention that we've heard about from the ACHIEVE study today. So clearly our work was cut out, but we didn't quite know where to start. So we had to go back and do some intervention development work, including scoping and intervention modeling. So for the next minute or so, I'll tell you how we did that. We started off by looking at actually what support care needs were for this population. So we looked at 3 different countries, 97 people with dementia living at home, with hearing and or vision loss and their care partners. And we scoped their support care needs, quality of life, as well as doing in-depth qualitative interviews. Now, those of you who are awake will recognize that there's a flag on here that is no longer part of Europe. And I started this work when I was in Manchester. And midway through the project, of course, we had Brexit. And so overnight, suddenly, we could no longer have European funding for the project. Hence my move to Ireland mid-project. So that was a big challenge in the whole program, which was sad and unfortunate, and one of the sort of inadvertent consequences of these kinds of political changes that we have to live with. But be that as it may, unsurprisingly, we found huge need of unmet support care needs for this population that is living with sensory and cognitive difficulties. And across a range of different domains, including psychological needs, physical needs, the desperate need for health information, particularly as it relates to the interrelationship between cognition, hearing, and vision loss, care and support. From the qualitative work, key themes emerge, again, allowing us to think about how we would develop our intervention. That tailored support care interventions were necessary. Not everybody could receive the same type of intervention. It had to be tailored and structured to their needs. Care burden, social isolation, and loneliness were absolutely key. And we've heard the beautiful presentation from Dr. Huang this morning. Now, she did not set up for my talk, but actually it's going to follow on quite nicely, as you'll see in a moment. And there was also the need for specific education regarding sensory age. So there was a huge gap, and we thought that all of these things needed to be addressed. So the next bit, I just want to focus on this issue of care burden, social isolation, and loneliness, which we've already heard about this morning. The Irish word for loneliness is wurgness. Now, if there are any Irish speakers in the audience, forgive me because I've probably not pronounced it correctly. I speak some languages. Irish is not one of them. It's a highly complex language. But it's also the word for grave. In other words, really underscoring the importance of this whole concept of loneliness and how it impacts on wellness, and in terms of also our mortality and morbidity overall. So it's extremely important and significant. And of course, we've seen this from Dr. Lynn this morning, this critical paper by Jill Livingston, which for those of you who aren't in the dementia world, I'll tell you that in the dementia world, this was absolutely a paradigm shift. That prior to about 5 years ago, when the first version of the study was published, we didn't talk about prevention. And now things have absolutely shifted. And in fact, this was the precipitant for the ACHIEVE study. But there's 2 points here. You heard about hearing loss, accounting for 8% of this model, the overall model accounting for potentially 40% of risk factors if they are addressed would in terms of dementia prevention. But social isolation is 4%. So between those 2 factors, actually looking at 12% of the model, which is far more than things like alcohol, for example, hypertension, diabetes. And in fact, why that's important is because, as we've heard this morning, these things are linked. So we looked at this link. Again, we've seen this breakdown already this morning, but we went back to the ELSA data and tried to understand how loneliness and social isolation mediate this relationship between hearing loss and cognitive impairment. And with some modeling, what we found, of course, as we know already, hearing loss and memory difficulties are linked, loneliness and social isolation are linked, but also hearing loss moves through loneliness to cognitive difficulties and through social isolation, mediating that relationship. So again, why is that important? Again, as we've heard this morning, if we address only hearing loss, say with aids, hearing aids, for example, we're not going to get the impact that we need on cognition. We need to address these other aspects as well, loneliness, social isolation, and hearing loss, because with regards to cognitive outcomes, these things travel together. There's something else that travels together in the story, and that's the next bit. Because again, I said I would talk about care partners. So we were very interested again in care partners because I almost never see a patient alone. They will always come to the clinic with a care partner, providing collateral, but also support. Very few, if any, people with dementia live by themselves independently without some kind of care package around them. So we wanted to look at this relationship between loneliness and social isolation in the person living with dementia and the impact on their care partner. And we looked at 95 clinic attendees, so dyads, them and their care partners, in 4 MASs, or memory assessment services, in the north of England. And in fact, what did we find? So we modeled baseline loneliness, social isolation in both the memory attendees, so the person with cognitive impairment, and their care partners, and the impact that it would have on mental health outcomes down the line. And what did we find? So if you look at the very top box there, so loneliness in the patient, the person with cognitive impairment, impacted on depression and anxiety in themselves 12 months later, but also in their care partners. The point being that not only do we have to think about social isolation, loneliness, and hearing impairment together, but we also need to think about the impact on the care partner, because dementia never travels alone. So this is where we talk about the care partner as the invisible patient. So these were key elements that we were thinking about in the intervention. The next key question we, of course, had to address was, this is an older population, a population that's frail, living with dementia. Can they successfully use hearing aids? And what does the evidence suggest with regards to that? Yes, there is some evidence that does support, at least recently, the use of hearing aids in older people, and suggesting that both age and severity of hearing loss are not strongly associated with hearing aid use in people with dementia, and that severity of cognitive impairment is not associated with hearing aid use in this population. But also we know that hearing handicap outcomes are better if hearing aids are used in the early stage of cognitive decline. So we started with some indication that we could go down this direction, but then we also went back to the literature. This is my lovely colleague, Emma Hooper, who's just completed her PhD on hearing aid adherence in people with dementia. Emma is an occupational therapist, so this area was very new to her, but she could understand that in the patient population that she works with, this has become highly, highly relevant. So she looked at the literature and picked out factors that influence hearing aid using the TDF, or the theoretical domains framework. Now, if there's any sort of behavioral psychologists in the audience, you'll be familiar with the theoretical domains framework, but essentially it's a tool that assists implementation of change by looking at various domains. And I'll come back to this later in the talk to explain a little bit more. But basically, it's trying to tease out what are the barriers and facilitators for a behavioral intervention, in this case, hearing aid use, across these different domains. So what she found from the literature, skills are important. That a person's degree of proficiency in handling the hearing aid is critically important for their use of the hearing aid. And that is important in people with dementia, and particularly in the population I work with, people with Lewy body dementia who may have Parkinsonism. Handling a hearing aid can actually be extremely challenging. Reinforcement is really important. If people have positive consequence of hearing aid, again, it fosters their use if they're actually getting a benefit. If the degree of comfort is important, and it's very common in our patients with population that they often don't like physical change, physical things touching, or even using things that are different or new, or changing established routines. These can all be quite difficult. The environmental context is absolutely critical. And also social influences. If people are getting social reinforcements of the use of hearing aids, that can impact on hearing aid use. So all of these things are important to think about. So taking all of these, putting them together, creating our intervention, and finally, let's talk about what that intervention looked like. So any complex intervention, a non-drug intervention, and complexity, actually, there's a very specific definition about that. It generally means it's an intervention that is tailored, that might not be delivered in the same way to each participant. You might also have a number of variables that have to be taken into account because the context may differ. In our case, it was across different European countries, and so on. So there is a definition of complexity. But every complex non-drug intervention has both components and implementation. So what were our components? We started off with a full hearing and vision assessment. Now, we randomized people to having a full hearing and vision assessment following a screen for two reasons. First of all, because if we did the full assessment prior to randomization, then of course we'd have an ethical problem of having to manage what we found in the assessment. And also the justification for randomizing was because, as we've seen from the initial slide, that the majority of people do not get an assessment. So it actually does constitute a novel intervention for this population. This isn't treatment as care as usual. They were then supplied hearing aids and glasses, and then critically, a sensory support therapist was put in place. Now, a sensory support therapist, again, going back to all the elements that we saw were important in this intervention, social isolation, loneliness, for example, care partner support, the environment, all of those had to be managed by the sensory support therapist. So it wasn't simply a matter of supplying hearing aids or glasses and then monitoring people, it's getting that in-home support with the therapist. Who was the therapist? Well, we purposely designed the job description that it could be anyone who has older adult care experience, so occupational therapists, social workers, psychologists, and again, this varied across our partner countries, but they had a core set of skills who were then trained up to look after sensory cognitive health, including the use of devices. And their job was to foster adherence support, manage the sensory environment, and educate patients at home about the sensory environment, so that you're not having critical conversations in the kitchen, for example, whereby you've got hard surfaces and the acoustics are difficult, that you might have them in a different area with soft furnishings. You might also think about things like the television being too loud, too soft, the lights being too loud, and so on. Communication training, and again, critically social networking, addressing that aspect of how the person's world may have shrunk as a result of their sensory cognitive change. So those were the components. The implementation was that we had weekly visits from the therapist over 12 weeks. These were home-based and again, critically care partner supported. So this intervention could not have succeeded without that dyadic support. So you could actually call this a dyadic intervention. We went off and did a feasibility test. I won't go into the details of this in the interest of time, but this was a small-scale open-label study of 19 partners, dyads, across 3 countries, and gave us an indication of how we needed to adapt the protocol, the intervention, but also what the outcome measures might be, and what we had chosen as our outcome measure, quality of life, whether that would give us potentially a signal. And that's very different from ACHIEVE, because of course ACHIEVE is secondary prevention, looking at change or slowing of progression of cognition. We weren't interested in that. We had people already living with dementia, and we wanted to improve their outcomes, top of the list being quality of life and well-being. So we tested that in the field trial and feasibility test, and then because we had a positive signal, we went on to the full-scale trial. So where did we do this? We did this across 7 different study sites, 3 of them in the UK, 1 in Ireland, but also France, Cyprus, and Greece. So you can imagine there were some significant challenges in terms of managing the teams, but also huge cultural differences in how people functioned. But that's story for over beer. We got there in the end. We initially had our sample size was about 354, but as I'll show you in a moment, we ran foul of COVID, but we were able to redo the power analysis based on the initial small sample, and we were able to get power for 252 dyads, which we randomized into intervention and care as usual. So who did we include? So we included people with mild to moderate dementia. So what does that mean? So dementia as defined by a clinical diagnosis of Alzheimer's disease, vascular dementia, or mixed dementia. We purposely excluded people with less common dementias, like Lewy body frontotemporal dementia, for example. We used a very pragmatic approach to looking for hearing loss and vision loss. And you can see here we used the Hear Check, which actually, even though this isn't that long ago, I don't even think is made anymore. So it looks like a piece of history, but nonetheless, it was extremely helpful because it was easy to use, a simple device that could be picked up. Everybody needed a care partner and had to be living at home. So how did we manage? With pain. So very happily in Achieve, you had a nice point at which COVID came along. We didn't. We were mid-flow when COVID came along. And in fact, the day of shutdown across the world in March, I was in Islamabad at a workshop and almost got stranded there as the last flights were shut down. So I was trying to hold study meetings on Zoom from Islamabad to try to keep this trial going. And we had to shift to online, and that was a huge challenge after an initial break. So that has made interpretation of findings extremely difficult. And what started off as being a definitive, beautifully designed trial, of course, has gone a bit pear-shaped. But we did eventually get there. And as you can see, over 76% completed the primary endpoint. So few things only. I'm just going to give you some highlights because I want to move to some other aspects as well. So you can see here with a fairly average age population. And my cursor isn't on, but in terms of dementia type down there, the second from the bottom row, you can see that distribution of Alzheimer's vasculism mix is very typical of what we see in a dementia population. So with the majority of people having Alzheimer's disease. But what was really interesting here was we were looking for people with hearing impairment and or vision loss. And in fact, if you can see here, 97% of our sample had hearing loss. Very few had vision loss only. So this is the sensory deficit that is all pervasive in this population. So it's either single or dual loss, but hearing loss is the core sensory deficit. And I think that's extremely important. So our primary outcome we chose is the DEMQUAL, which is a dementia quality of life scale specifically designed for this population, developed in Plymouth by Professor Subi Banerjee, and performs extremely well, looking across a range of different domains. And we looked at the primary outcomes being 36 weeks post baseline, as well as secondary outcome at 18 weeks. And we didn't see significant changes at the 36-week point, keeping in mind we had all the complexities of moving online and gaps because of COVID. But nonetheless, the DEMQUAL was slightly higher in those who received the intervention. At the 18-week point, the adjusted DEMQUAL was significantly higher. And of course, that would have been much closer to receiving the intervention. If you remember, that was 12 weeks. So what does this mean? Difficult to know. Is this because of the disruptions of COVID? Is it because we don't have a strong effect at 36 weeks? Or is it because actually you need to have that ongoing support from the therapist to try to maintain your quality of life outcomes in relation to your sensory intervention? So these are all things that we're still trying to work out. We did not see significant differences in 36 weeks across a range of top-level secondary outcomes, but unpicking these, which we're still in the process of doing, there's some very interesting findings related to subdomains of the neuropsychiatric inventory, for example, and likewise care partner experiences, particularly the difference between single and dual sensory impairment. We did some qualitative work using grounded theory analysis, and we came up with a number of different impact domains, and I'm just going to share some of them with you because I think, again, you know, the longer I've kind of been in the field of dementia care, the more important these outcomes have become for me. These are the things that I find are meaningful rather than changes by a few points on a cognitive or a quality of life score. So you can see here, we've got quotations of greater awareness, greater knowledge as a result of being in intervention, improved socialization, less care partner burden, increased self-efficacy, and even improved cognitive ability. My thoughts are clearer, my memory's been helped a little bit. So these are the things that actually make that real world difference. What we're currently doing is the black box analysis, because again, as you heard today, that those process measures and understanding actually what happened in the intervention, who got what was the dose, how many people had good fidelity to the interventions are all critical when understanding complex interventions. And it can take quite a while to unpick that. So I'm not going to go through this in too much detail, other than to say a few things which I thought might be interesting. In terms of the people who received a hearing assessment, 81 of them received a hearing aid. So these are people living with dementia. And I think that's a high proportion. because there is quite a sense of nihilism within the audiology community that I've experienced with regards to people with dementia. And this is even exaggerated in people living in long-term care. The idea that people cannot benefit from them, or the adherence is very low, or it's not worth their while. But ultimately, in talking to care partners and also talking to formal carers about this issue, this isn't simply a matter of giving a person a hearing aid. It's about their right to communication. And I think that's a critical point that needs to come across, particularly in long-term care settings. It's about a person's right to communicate. The glasses are interesting, 35%. Now, when have you seen an older person come into a memory clinic who isn't wearing glasses? Everybody's wearing glasses. But the point is, are they wearing the right glasses? When was that prescription last changed? And that's a critical point, keeping these prescriptions up to date and ensuring they're getting the right aids. Now, adherence, I'm going to talk a little bit more about that later. We do have the data logging, which we haven't yet analyzed, but this is just a Likert scale of self-reported adherence on a scale of 5. And you can see that across the different countries, a fairly high self-reported adherence rate. And again, because we, I believe, had the support of the care partner working as a dyad. So let's touch on hearing aid adherence, which is absolutely critical in this population. So coming back to the work of Emma, so she, after her systematic review, she did a couple of other studies, one looking at qualitative work for enablers and barriers to hearing aid use, but also some looking at the correlates of hearing aid use using the baseline data from SENSE-Cog. And the way she did this is, again, coming back to this TDF. Now, the theoretical domains framework is a way to operationalize a behavior change model called COM-B. And again, for those of you who are behavioral psychologists, this is one of the gold standard ways of understanding how behavior change happens, whether it's smoking cessation, weight control, or hearing aid use. So your behavior in this case is hearing aid use. Your COM-B is capability, opportunity, and motivation. And you need to look at all of those factors to ensure the behavior change occurs. And those can be operationalized across these different domains. So what she did is that she looked at her variables. Her outcome was hearing aid use, and the predictive variables were balanced, or at least categorized across these different capability, opportunity, and motivation categories using the COM-B model. And why is this important? Is because then rather than just simply giving you a list of predictors, it gives you a list of factors that you can then action, and you can make a difference and design your interventions around this. So let's go through them. So in terms of the capability, the key factor here was cognitive ability was absolutely critically important in terms of hearing aid uptake. Now, it turns out it was the same as the general population, and that's important. In other words, people with dementia can have the same hearing aid use. However, one needs to consider things like executive function and functional ability when understanding and implementing these hearing aid use in people with dementia. In terms of opportunity, now this was quite interesting. This is about country of residence. So with England as the reference, now why England? Because it has the National Health Service, and under the NHS, hearing aids can be supplied as being subsidies. But a few interesting things came out. Turns out that Greece, which does not have subsidized hearing aid use and they're always private pay, had the same level of hearing aid use and uptake as England. In other words, the subsidy element actually is probably less important. There are other factors going on, cultural factors. So it's a far more complex issue than simply saying that if you get your hearing aid for free, that means the uptake will be really good. France, again, is another interesting observation because it is different to England, and yet it does have subsidies. Having said that, uptake has increased recently since the subsidies were introduced, which were very recent. So it just kind of adds to this complexity of who and why people are using hearing aids in the older population with dementia. And finally, hearing acuity. So what we saw here was the acuity negatively was associated negatively with hearing aid use. In other words, higher hearing loss with higher hearing aid use. And this again aligns with the general population. But of course, the challenge is that if the idea is that you want to introduce hearing aids earlier, one has to work a little bit harder to ensure that that happens. And again, that point was made this morning, that it's people in the very early stages who are not taking up hearing aids. And if they are important in terms of cognitive decline, that's a critical point. So just pop this in because this came into our inbox, mine and Emma's inbox just a couple of days ago, and it's about the real world impact of her work. So her article was just recently published, and this group of speech and language therapists picked it up, and you can't see it here, but they've come up with a bunch of recommendations based on her findings. So again, it's a very nice output in terms of a research finding. So let's shift out of the home and into the long-term care setting, the care home setting. So in Ireland, it's a tiny country. We've got a population of 5.6 million. We've got 64,000 people living with dementia, which I realize in the United States sounds ridiculous, but for a small country, that's a lot. And of course, a significant proportion of those will end up in long-term care, as they will here in the United States. So we need to be thinking about this population and their sensory health needs. And there are huge gaps in this population living with dementia, less so in the overall care home population. But that subset, 60% in fact, of care home residents have dementia. They're the ones with huge gap in their care. So the next few slides, I'm just going to explain how we are adapting the SENSE-Cog intervention designed for a dyad to be delivered at home on a one-to-one basis with a therapist into a highly complex setting of the residential care home. So we couldn't just cut and paste the intervention. We had to do a lot of work, which we're now doing. We went back and did a systematic review. We did a CAP survey, knowledge, awareness and practice survey with professional and lay stakeholders working in care home settings. We looked for theoretical framework. And finally, we've developed a complex non-pharmacological multi-component intervention appropriate for care homes that we are now pilot feasibility testing in a cluster RCT. What did the systematic review show? There are a number of barriers and facilitators, which I'll go through very briefly here. Whoops, where did it go? Whoops, whoops, whoops. This is interesting. Oh, never mind. Sorry. So I'm seeing all my slides now. Bear with me. There we go. Okay, so results of the systematic review in long-term care. What are the barriers to hearing aids use? Staff awareness and staff knowledge is a huge one, and that comes across the board in terms of the literature. So in not picking up the fact that people are living with sensory impairment and not referring them for assessments. Limited rehabilitation approaches and adherence. So if people do have hearing aids, there's a huge reluctance to use them. Staff are afraid of using the hearing aids because they're expensive. If it's $3,000 or euros for a pair, they want to tuck them away in a drawer rather than giving them to residents, because they end up, as you all know, in pieces of tissue or in the laundry or in the drawer. Now, not in the dog's mouth, because there are usually no dogs in the long-term care settings, but wherever they end up, they don't end up being used by residents. So there's a huge reluctance for staff to be using hearing aids, even if they are prescribed. And the sensory-friendly environments. So for those of you, just out of curiosity, anybody here been to care home, working care home settings? Okay, very few. So strongly recommend that all of you in hearing health go and visit care homes, because it's a remarkable experience for the less well-run care homes. They are noisy, sensory unfriendly places, loud televisions, bad acoustics because of infection control, so a lot of hard surfaces, very unfriendly lighting, so no ability to tailor to the person's sensory needs. If they're photophobic, for example, or they need more light, or if they're got hyperacuity, for example, all of these things cannot be taken into consideration because people live in an institutionalized setting. So hugely challenging from the sensory cognitive perspective. So I'll just very briefly go through our CAP survey, just back for a minute. So we did this knowledge, awareness, and practice survey of care home staff across various grades. We did it in a number of countries, as you can see here: England, South Korea, India, Greece, Indonesia, Australia. But I'm going to focus here on the English data because I think it really provides the impetus for doing this kind of work. So with nearly 900 staff, there's a whole range of reasons why staff are not comfortable handling hearing aids, and they're all very basic and predictable. They don't know how to handle them. They're afraid of them getting lost. They don't know how to change the batteries, for example. We looked about their knowledge, and we could see that it's extremely low across the different types of professionals, whether they're cognitive, hearing, or visual professionals. that the knowledge of how positive screen impacts on dementia is very low. But they did look for the perceived, they did admit to the perceived usefulness of guidelines. So they're desperate for the knowledge. Now, I won't go through I think I've taken out my other slides. Oh, and I've got a couple more. So you can see here, although there is an awareness of sensory cognitive health, actually, the ability and awareness of how to screen for this and act on this is very low. Arguing for a huge role for education for care home staff around these very basic issues. So with that knowledge, we then looked for a theoretical framework around which to develop the intervention, and we came up with the model of place. Now, a model of place is a theoretical framework of how to do interventions in care home settings. And essentially what it is understanding the different complexities and levels that you need to intervene at. You started with a resident, but the resident comes with a family. But then there's also the level of the staff. And then there's the level of the environment. And then over and above is the level of the organization and the links that they have to providers. So essentially, it's all these different layers. So we've taken that model and turned it into the sensory cognitive model of the place, thinking that our intervention has to address each of these levels. At the residents, their personalized sensory profiling and intervention. The staff level, here we need to be educating and putting in place a sensory champion and upskilling one of the care staff or 2 care staff per home in all the complexities of hearing aid adherence and also managing the sensory environment. Thinking about the environmental level, doing a sensory audit of the home. And this isn't about knocking down walls and things like this. This is basic stuff like thinking about the television volume, thinking about the lighting, even the smell, all these kind of sensory factors that can be changed if one is aware of them. And finally, the organizational level. Certainly in Ireland, there are care homes that don't link with providers for hearing and vision care. And that's a huge problem. It depends on the family members to advocate for this care for residents. So unless you're looking at all these different levels, you're going to run into trouble. You cannot simply be replacing or using hearing aids. So that's the care home. Now, I'm going to move to the final bit, and I think I'm okay with time here because I haven't had a warning yet. Perfect. In the lower and middle income country setting or the majority world setting. And I think this is where the impact of this kind of work can be huge. So I'm going to take you through for the next few minutes how we adapted the SENSE-Cog intervention and feasibility tested as a very first step to thinking about rolling out this type of intervention in different settings. There we go. I've already mentioned this global challenge that the majority of people living with dementia, and I say living with dementia because the at-risk population is even larger, are living in the majority world. And the whole dementia prevention story is actually more important in this setting than it is in higher income countries. So we know from Jill Livingston's work that we can potentially prevent 40% of dementia. If you put that in a majority world setting, you're looking at 55%. And some of the key factors, of course, not only hearing impairment and so on, but air pollution is a critical factor. And I believe, and I've never found the reference for this, but I understand that people develop age-related hearing loss 10 years earlier in many lower and middle income countries than they do in high income countries for a whole host of factors because of higher rates of vascular risks, but also air pollution. So for those of you who have been to places like Dhaka or Cairo or Delhi, or Mexico City, the air pollution is huge. So a risk factor not only for cognitive impairment, and that's part of Jill Livingston's model, but also for hearing impairment. So adding to those risks. So the risks are big, but there's also huge potential. The challenge, of course, is that in many low and middle income countries, stigma is very high. In some countries in Africa, there isn't a word for dementia. In some countries, and again, thinking about our GBHI fellows, a person with dementia who wanders out at night in their nightie may be branded as a witch and killed. There's a lack of understanding as dementia as being outside of the normal aging process. So even if people are living at home and have care, they might drift into dementia without anybody recognizing that this actually shouldn't be the case and they need support and care. And limited health and social care ecosystems for older people's mental and cognitive health. So massive challenges, but huge opportunities as well. So this leads me to the SENSE-Cog Asia program. So we worked with 7 study sites in South Asia, 3 in Pakistan, 3 in India, and 1 in Bangladesh. And we wanted to adapt the intervention to these contexts to see whether we could undertake this intervention. But it's a lot of work that's required, because the first was capacity building. We actually had to set up an infrastructure that we could even deliver a trial of a non-drug intervention. And that involved public and patient involvement. Then we had to adapt the intervention, and then we had to do the trial delivery, feasibility, and acceptability. So all of this long before thinking about an effectiveness or an efficacy trial. So these are some of our partners in terms of capacity building, as you can see here in Mysore, Chennai, and Bangalore, and also in Pakistan. And we did some intensive capacity building in terms of training, but across multiple levels, because training isn't just about the trial, but it's about how to conduct clinical research, also thinking about the ethical frameworks, also managing international collaborative working between high and low income countries, particularly when the money comes from the high income countries and some of the expertise and the protocol might come from high income countries. There's huge potential for this notion of research inequity and imbalance and research imperialism that we need to guard against. And so a lot of work also went into developing a framework for how to achieve balance and equity in that international collaboration for dementia research. And then a lot of work also went into developing the pathways. In other words, the logistics. We cannot be doing an intervention with people with dementia if we don't have clear-cut memory clinics, and we can't actually find people. So a lot of work had to be done in that regard as well. So here's some of our training. And absolutely critical to this was patient and public involvement. So going to people on the ground, living with the condition and getting their feedback. And they were called the Research Advisory Team. And their role was to help us understand how this intervention will work in real life across these different contexts. And here we are lumping together South Asia, but you can imagine, there's over 100 different languages, and also think about the socioeconomic disparities and the religious disparities across all these different countries. So everything has to be tailored to the local context. And this is critical, because unless you get this right at the outset, you're wasting your time, because your intervention will end with a study, rather than, as we heard this morning, that critical need to move into implementation and getting meaningful outcomes, particularly when you have something that's so pragmatic and so basic and is a basic right to communicate. The potential is huge, but you've got to get it right. So how did we do PPI? Well, we leaned on the Wellcome Trust's public engagement onion. I won't have time to go into it, but essentially it shows all the different facets of patient and public involvement, all the way from light touch engagement, all the way to deep, the other way around, involvement, all the way to engagement. And engagement is where you have people with lived experience informing your intervention, telling you how to do it, how it's going to work, or what won't work. And each team across the 7 sites picked a different part of the onion to try to understand how they would do this. And for those of you who are interested, you can read that in our publication. But one of the things that they did is produced a newsletter, which was lovely to keep all our sites together and working. And I said that the European working across 7 different sites and cultures was challenging. Working across 7 sites in South Asia was vastly more challenging, I can tell you. So lots of interesting learning, but also wonderful experiences. So after the preparation, cultural adaptation, there was a number of things that we had to change. Obviously, the language had to be language appropriate. And I say hearing intervention only because, of course, SENSE-Cog was hearing and vision. But everybody decided, let's keep this basic. Let's go with hearing. We did fewer visits, shorter visits. And this was a critical piece. In our SENSE-Cog, we didn't focus on dementia education. We focused on hearing and vision and communication. Here, however, the dementia education piece was critical because nobody talked about dementia. The recognition of dementia was low. Our starting point was hearing impairment. In other words, we were using hearing impairment as a kind of Trojan horse to start talking about dementia, to do the cognitive test, and then open up those discussions, rather than the other way around. So it served a very different purpose, but again, had that kind of effect of saying, let's change the conversation around dementia and cognitive health within this context. And of course, we had to look at outcome measures and materials, and all this work had to be done. We then went into the feasibility and tolerability evaluation. Will this work? We did it as a single-arm unblinded feasibility test, and we included various people. I won't go through the details of this other than to say that we used a very basic, pragmatic screening approach, and these were our outcomes. So we had a number of dementia-related outcomes, but those are all exploratory, just finding out, will these tools work? Are they appropriate? Can people tolerate them? Our key issues were feasibility, tolerability, and acceptability with a priori definitions for all of those things. What was our main outcome? Was the traffic light go, no go approach. In other words, will this work? Off we go, we do a definitive trial. If it's amber, well, it might work, but we need to do adaptations. Or if it's red, stop, forget it, you're wasting your time. No point in sinking a lot of money into a definitive trial. So that was our main outcome, go, no go. Now, I won't go through this in too much detail because it's not that interesting, but other than to say, we did find that we could, in fact, recruit people, which was good. Although in some cases, there was a lot of suspicion around this. Why do you want to interfere with me? Are you going to pay me? What do you want from me? Are you going to use my data? Are you going to do something strange? People were not used to clinical research. So there's a lot of explanation that had to be done that was different to running a trial in Europe. Our intervention delivery showed that we could deliver about 85% of completion, which was pretty high. And we had pretty good data entry. So a lot of pieces were in place with reasonable ratings on tolerability and effort, understanding and motivation. And I'll just move through these quickly, because ultimately what we did was also look at some qualitative outcomes, and a number of different themes emerged, very similar to what we found in Europe, about improved functional ability, good acceptability of the intervention, increased knowledge awareness, care partner burden. Father's responsibility is less now. He takes care of himself, so I can focus on my housework. And again, the burden of care on women particularly is absolutely huge in South Asia, particularly daughters-in-law. So this is not insignificant. And I realize I'm running out of time here. So we looked at the DEM-call and the sensitivity. And again, this doesn't mean too much because it was open label, but it just allowed us to look at the translations and how it performed. And ultimately, we then applied our traffic light, looking at a priori outcomes. And putting together the synthesis of findings, we came out with an amber, an orange light. Essentially, yes, a lot of this works, but we still need to make a lot of modifications. And that's where we are now. So we're on the point of deciding whether we go for a definitive large-scale trial in South Asia, which I think will have important impacts. But we have had lots of learning and lots of things need to change before we can do that. So I'm going to end there, and I'll just go to my last slide to show you. There we go. Yeah, okay. Thank you very much for your attention.